This program is brought to you by Community Trust Bank, Medical City, Bid Select, and the Neely School of Business at TCU. Welcome to Platforms, the life-lifting news program for women. Now, here's your host, Siobhan Palmer.
Hey, welcome back everybody to Platforms, the life-lifting news program for women. We're continuing our conversation with Dr. Mitch Magee here at Medical City, Dallas. Dr. Magee is a surgeon here, and when we went to break, Dr. Magee, we were talking about your subspecialization here as a cardiac surgeon. Why don't you expand more on that? It's very interesting.
Well, one of the things we were talking about was what is minimally invasive surgery, and I was talking a little bit about how my specialty of cardiothoracic surgery has evolved a bit into one very focused on minimally invasive thoracic surgery. Increasingly, all of medicine is becoming more and more subspecialized, and it's very important when you're choosing a surgeon to choose one that is focused and trained particularly in less invasive techniques. As I alluded to, there are important ways and an approach to selecting the right operation for the right patient. Whether that's minimally invasive or not is really going to be up to your surgeon, and if your surgeon is not trained and experienced in less invasive techniques, and that won't even be an option that's considered for you.
Yeah, exactly.
So that's very important. And as I said, more and more of us are becoming, we're learning more and more about less and less and becoming more and more highly specialized in certain areas.
Niche, yeah.
And that really is much better for the patient. So
sure.
Again, when you're choosing a surgeon, when you're choosing a physician, you want to make sure that you choose one that's specialized in general thoracic surgery, that doesn't do cardiac and thoracic and basically try to do everything, because it's harder and harder to do, especially the highly technical
challenging
subspecialty surgeries that we do.
Dr. Magee, there is a surgery that you do. You're one of the few surgeons in the country that does it. It's relative to cancer of the esophagus. Tell us about that procedure. It's remarkable.
Sure. Well, we touched a little bit about the increasing incidence of lung cancer and the fact that lung cancer is genetically based and does have some environmental factors. Of course, smoking contributes to it, but if your parents smoked and you didn't, you still have an increased risk of lung cancer because of that genetic risk. Another rising cancer in incidence is esophageal cancer. That's related to the epidemic of obesity, and also a very common problem that many of us have, reflux.
Reflux disease,
yes,
yeah.
Gastroesophageal reflux disease, also referred to as GERD, G-E-R-D. And there is a rising use of antacids. There are a lot of antacids on the market now. Many of them are now available over the counter. And with the rising problem of reflux, and obesity aggravates reflux, there's been the development of a problem called Barrett's esophagus, which is a change in the lining of the esophagus in response to that chronic acid exposure.
So constant irritation, it just builds up and then creates an environment, yeah.
Exactly, and that environment then can evolve into a cancer. So Barrett's esophagus is a problem that is associated with chronic reflux, and despite the use of antacids, it can still continue to develop. And once it does develop and evolve into a cancer, which typically occurs at the junction between the esophagus and the stomach, then it has to be treated, and often treated surgically. Now, again, like many cancers, the key to treating it is catching it early.
Right, exactly.
And so by screening patients for gastroesophageal reflux disease and the development of Barrett's esophagus, then a heightened awareness for the possibility of development of esophageal cancer can help catch that at an early stage and at a very treatable stage. The best treatment is going to be surgery, but many patients present at a late stage where surgery is no longer an option. If surgery is an option, esophagectomy, which is the removal of the majority of the esophagus along with the cancer, is the treatment of choice for esophageal cancer, if it presents at a stage that is amenable to surgical resection. That is typically one of the biggest operations that patients can go through. It's a huge operation traditionally, but one that has recently lended itself to a less invasive approach, which I've been able to help many of my patients with by offering them that less invasive or minimally invasive esophagectomy. Typically, it requires 3 incisions. In the open approach, we make a large midline incision in the abdomen, another large incision across the back of the chest, going between the ribs and spreading the ribs, and then another incision in the neck. And we take out all of the esophagus between the neck and the stomach, and then refashion the stomach into a tube, and then bring the tube, refashion stomach as a tube up into the neck, and sew it back into the remainder of the very short segment of the esophagus that's left in the neck.
So the tube is kind of a supplement for the esophagus?
It's a replacement. For the removed esophagus. Now,
wow.
As I said, I'm now doing that through a minimally invasive approach where we do all of the abdominal part through the laparoscope, through small incisions, insufflating the abdomen as we were talking about earlier. The chest part we do through 3 or 4 slit-like incisions between the ribs, again, without spreading the ribs or opening the chest. And then the last incision is, and the biggest incision on the body is about 2 or 3 inches long at the most in the neck. We still do the exact same operation. As I said before, it's very important to do the same operation closed as you would open.
Right.
And in fact, the outcome is tremendous.
It's remarkable.
Yes.
But you said something earlier that really resonated with me, because sometimes when you're trying to save time and pain for the patient, that challenge transfers over to the surgeon, because you want to make sure minimally invasive surgery is the best procedure for both the patient and for you to be effective as a doctor, right?
Right,
yeah.
right. Absolutely. And so we can't compromise any of the cancer operation. And doing all of that operation through small incisions is very technically challenging to do and time consuming. So the operation ends up being a couple of hours longer than it would be open, but that more than pays for itself in the post-operative period when patients are still in the hospital 5 to 7 days as opposed to 10 to 14. Right. And then again back to normal activities within 2 to 3 weeks as opposed to 6 to 8 weeks.
I wanted to ask you too, when do you determine to bring in a robotic system to supplement or add to the laparoscopic procedure? How's that determined? Well,
we were talking about buzzwords in surgery, and minimally invasive is definitely one. Robot and laser are 2 other ones. And again, I think there are a lot of misconceptions surrounding those terms. Again, I think the robot in some specialty areas and in some procedures can definitely offer advantages. I think in gynecologic surgery and in urologic surgery there have been definite proven advantages. Those advantages have been less proven, I think, in some general surgical procedures and definitely in cardiac and thoracic surgery. But we're still open. I was involved in some of the early development of procedures with thoracic surgery and the robot, and cardiac surgery procedures as well. And at the outset, at that juncture of technology development 10, 12 years ago, the benefits were not there. But I think as technology evolves and the robot evolves with it, there will be opportunities again to consider the robot. And I think it's one more tool, one other technology that we have to keep in mind. Yeah.
Dr. Hold that thought. We've got to go to break. When we come back, we'll continue our conversation with Dr. Mitch Magee from Medical City, Dallas. This is Siobhan Palmer with Platforms, the life-lifting news program for women.